home delivered meals, which is a very important HCPC, especially within the Medicare Advantage program, and very significant to interventions for food insecurity among the aging population. So we heard some pretty important comments from a few different organizations regarding making sure that this got back in. So we've had a flurry of phone calls to try to make sure how to do this well. So one was the Agency of Community Living with their work and their consultants. They're doing
Phew, that took a while.
Oh, sorry. They're doing some coding and reimbursement initiatives and breaking down the S5170 with different modifiers so that they can represent concepts of in-person delivered, home delivered meals, in-person delivered medically tailored meals, mailed alternative meals, and mailed alternative meals that are medically tailored. So with their suggestions, the possible concepts that we could include for code would include those 3 new codes. However, what we have to do is integrate the request for these codes with the work of the Food is Medicine Coalition that have been working on a HCPC code for medically tailored meals for some time. So the idea would be that there might be, first hypothesis or first suggestion is that there would be the baseline S5170 code and then these 3 new codes to represent medically tailored both in the in-person delivered and mailed space, and then creating the addition of a modifier that could allow each of these meals to be represented mechanically altered in the presence of dysphagia. We were hoping to have some members of the Agency for Community Living on the call. Can someone type in if there's someone from, so Lucy Johns, so sorry not to understand mailed, meaning drones. So I love that comment. So one of the things that's happening in the medically tailored meal space is that some insurers are delivering via the mail, packaged and sent from a central distribution agency, meals that have been medically tailored to the person's chronic disease and nutrition status. Also, yes, so FedEx or UPS next day. There's all kinds of different ways that this is happening, and the request of Agency for Community Living was trying to differentiate in this space the meals that are delivered by the person, because remember, medically tailored meals, according to the work of the Food is Medicine Coalition, are a trifecta of intervention. So you have the nutrition sculpted, you have the meals that are sculpted for the chronic diseases of the person, you have this in-person safety check, and then you also have nutrition education. So Lucy John's wondering, so why does this matter for population health and SDOH? Because these meals are pretty critical interventions for folks who have co-occurring chronic disease and food insecurity. In fact, there's a wealth of literature on the role of medically tailored meals post-discharge, preventing readmission for co-insured food insecure and chronic disease patients. Certainly, home-delivered meals are incredibly, like as it stands, which is often we talk about plain home-delivered meal as the meal on wheel concept. In many areas around the country for undernourished, socially isolated older adults, that program is a nutrient and social isolation intervention for food insecure individuals. Oh, the reason why it meant mailed, why does this mode delivery matter? It mattered to the Agency for Community Living folks. This is why it's up there. It doesn't necessarily need to stay as suggested. One of the things that I asked, one of the folks I asked to be present was the Food is Medicine Coalition. Are any representatives of FEMIC on the call today? It looks like.
Yes.
Hi.
Hi.
Is this Alyssa?
It is.
Hi, Alyssa. Nice to hear your voice. So I'm wondering if
you too.
I wonder if you can weigh in on some of the work that FEMIC has been doing in the work for coding and HCPCs, and what your thoughts are about these options.
Yeah. So we've been thinking about this for quite a while and bouncing some ideas off Sarah and all of the experts. But I think the idea is really to think about how we're talking about meals. we want to preserve the concept of an intervention, I think, when it comes to medically tailored meals, and make sure that it is incorporating the RDN involvement, the ongoing nutrition counseling, the referral by a healthcare professional, and then the layering of diet. That's really what makes a medically tailored meal. It's not just a diet, it is the layering of diets for multiple comorbidities. So I work for God's Love We Deliver here in the city, New York City, and most of our clients are living with 4 or more conditions at any one time. So it's really critical to have that clinical expertise, and that's what makes a medically tailored meal. So I think really what we're looking at is, does it make sense? And I think this is a question, and we look forward to, I think, working it out and having further conversations. Does it make sense for that type of clinical intervention to be a subset of home delivered meals, or is it actually something different? And so I think that the questions that have been raised, even just on this call, because I raised the same one about, does shipping matter? Is it a significant enough thing to make it a modifier or a different intervention code? I think those are questions we need to answer. But I think where we landed from the Food as Medicine Coalition perspective is really that medically tailored meals might need its own parent code. And so I think that this is really critical in order to describe the type of intervention. And I think that's kind of where we've gotten.
So I'm wondering, so just trying to synthesize some of the recommendations that I'm hearing from the chat. Again, this was the recommendation as coming from the Agency for Community Living. So I'm wondering if we can just propose multiple modifiers. And one of the things we could do is actually entrust the Food as Medicine Coalition to work with the representatives from Agency for Community Living to really refine this over the next few days, because the timeline on this was very short. So we finally got a phone call with Agency for Community Living on Tuesday afternoon. And then I wrote Alyssa like a very short while ago. So one of the things we could do, again, to try to minimize the amount of codes and make things intelligible, is to clearly suggest a new HCPC for medically tailored meals, but then used, like, if it's not in-person delivered, as another modifier. So you have multiple modifiers for mechanically altered and not in-person delivered.
All three of you and I, we need to sit down and talk.
Can someone mute their phone?
The sooner the better. Obviously.
Thank you. So I'm just going to repeat that comment. Is there could be just a very clear recommendation for the distinct new parent HCPC medically tailored meals, and then conversation regarding these modifiers. And one of the things we could do is actually just suggest again that FEMIC and Agency for Community Living refine those suggestions and get them back to us for the consensus review starting on Thursday.
I think that sounds like a wonderful idea. I think that there's a lot of synergy here, and just getting us all together to kind of nail it down would make sense. God's Love has quite a bit of experience with modifiers, working in the healthcare space in New York State. So I think we could add some background there as well, and we would completely welcome that. I think that's the best idea.
Does that seem good to the community? So one of the things, so Karen Nichols' work is she lost audio. Are other folks able to hear everything? It seems like we're having some audio issues, and I apologize for that. Okay, so I'm going to propose a recommendation then that again, there's been a flurry of activity in these last weeks to try to make sure we're not missing things prior to the consensus review and consensus meeting. So I'm just going to make a kind of a motion that we connect FEMIC and Agency for Community Living, since FEMIC is really the expert in this space, and Agency for Community Living is the expert of the on-the-ground work. And then they refine a suggestion and bring it back to us in short order. Any objections to that? Sounds like we're okay. Okay, so next slide, please. Diagnoses update slide.
Sarah, sorry, this is Lisa. I was muted. I'm trying to speak up for Bill Swan, who had a question on your previous slide around the definition of alternative in the context of what do you mean by an alternative meal?
So this is, again, this is one of the, I wish folks from Agency for Community Living were on the call. We were hoping to have them here. These are definitions as defined by Agency for Community Living. So one of the benefits of connecting them with the Food as Medicine Coalition is all of these concepts are very clearly defined in FMIC, differentiation between medically tailored meals and medically tailored groceries, clarifying what an alternative meal might be. And so one of the founding principles of Gravity is that we have common definitions. And so what we could do then by connecting is make sure we're all on the same page. And then there's a comment from Jane, suggested the group that addresses this aspect, mode of delivery matter for transportation. I wonder, you mean the mode of delivery? Jane, do you want to unmute yourself so you can help me understand?
Yes, this is Jane. Can you hear me?
Yes, I can.
Okay, I was just going to suggest that whatever, I think that whatever resolution we have, and I'm certainly impressed with all the work already going into it, that that group keeps in mind that we may find ourselves as we continue working through, for instance, transportation or housing, some of the same question. What's a modifier? What belongs in as an intervention? So I know we're focused just on food, but if we self-define the modifier in a certain way, then it might force us to a point where we'd have to unravel something in order to talk about mode of delivery for transportation. Doesn't matter if it's Uber, Lyft, or a family member, or even housing, and how that any intervention is delivered. But I would agree that in this particular case, the mode of delivery is part of the intervention. It's one of the attributes of the intervention.
Yes, and I think the thing is I really appreciate your request to make sure we're thinking globally. What I hope can happen out of this is the intent, which really was to represent the uniqueness of in-person medically tailored meal program, that we can think about a way to represent that through the work of FEMIC. But I do agree that when we consider modifiers, we really need to make sure we're thinking about next stuff too. So I will see how we can put that in the cogitator of my of this space. And I really appreciate the question. Did we answer Bill's question? Are all the questions on this slide answered before I move on?
Yes, I believe they are.
Okay, thank you. So moving on to diagnoses updates. So this actually represents moments where the SMEs group, the group of subject matter experts, really went deep into trying to talk with all of the colleagues in this space about creating a really clear recommendation on the diagnoses modifiers question. So Donna and Tina went deep into the work of the A&D, and then I contacted all my colleagues at the USDA and Food Research and Action Center and Children's Health Watch and Feeding America. And we want to state at this time a recommendation and hear what the community's feedback on this. At this time, what we're saying is I feel like there's consensus that we can know what we mean when we say mild food insecurity, moderate food insecurity, and severe food insecurity. And we've clearly heard from the work of others how representing that severity is important in this space as we work to match severity with interventions and evaluate outcomes. The literature on temporality is so novel and as yet it has not settled, I'm going to say that our recommendation would be to just build the severity codes at this time and wait to build out the temporality codes when the literature has really clearly taken a stand on that. Understanding that the way we have them built here will allow for future specification with temporality when the terms are ready to be inserted. So the parents of mild food insecurity, moderate food insecurity, and severe food insecurity would remain, and the temporality children could be inserted in time. Anyone have any thoughts about that? It's our suggestion based on the literature at this time.
Can I make a comment? It may be a little bit too long to put in the chat.
You can certainly make a comment. Do you want to just, yeah, come. Is it Lucy Johns?
Yeah, I'm wondering if the Gravity final report could have really two distinct parts. One captures everything that we've been doing based on the use case and based on all the expertise that has gathered around this project. And the other is ideas that came up, but they're not sufficiently developed for us to have in the actual report, but we want to alert the entire audience for this work that these are things that need to be thought about in the future. Is that a possibility? So we don't have to solve every single semantic or code problem put before us, but we want people to know that things have come up and somebody's going to have to deal with this.
So Lucy, 100%. And there's been many concepts that have come up. Like I think one of the early significant ones was the lack of a taxonomy for the programs and roles themselves in the community space. So we early identified that we would need to create consensus on how we name the things we do, not just the activity to get to them, and how we name the roles in the community. And we put that in what we call the parking lot right now. But really talking about future implications and future work and holding space for that is going to be a significant part of that report.
I really encourage future implications where we mention things that we think are important, but we don't have resolutions or recommendations in the timeline available to us.
Yeah, or it's not practical yet, but we want to build a world where it could be.
Right.
So
Great.
yes,
thank you.
100%. So, oh yes, Deb Donovan says, I'm sorry, just to go back to the chat, Deb Donovan was talking about whether or not mild, moderate, and severe will be defined. And yes, they will be. A few sessions ago, I presented the mappings of the concepts of food insecurity that match to the severity. Those will be part of our final report to make sure it's disseminated into implementation. And then Lori, can be used for all social needs and can be universally defined. That's a brilliant idea, Lori. I think that should go I think we should include that as part of our recommendation. Thank you. Any other comments on this slide? It's been a lot of work to get here, so very grateful for everyone's input. And I do want to state that I
think you're keeping up, Sarah. I'm thinking you're doing a great job with the Q&A chat.
Oh, thanks. You can tell I'm a seminar, I guess. This is my happy place. So one of the things I wanted to state, and you'll see this theme as we go forward with much of the stuff that Donna will present, is the simplicity of that first parent, food insecurity unspecified. We do always need to build it a way for people to do the easy thing. So if you do not want to assess the granularity, we are going to make sure that we hold space for a concept that is not further defined. So just to create simple implementation in people that have bandwidth only for that. It sounds like we are okay with this. Why wouldn't we say food insecurity? Oh, we will say food. So Corey Smith is wondering why wouldn't say food insecurity versus unspecified. That it will say food insecurity SNOMED, but when it comes to a possible taxonomy in ICD, if there's a parent if there's a concept that has further stratification, but it has not been stratified, you want to build in the understanding in that unstratified parent concept that there's more that one could do. It just hasn't been done. So that's why I put that there as a placeholder in the parent. I'm thinking about the ICD-10-CM application that I did with Blue Cross Blue Shield with the help of AHIMA, and just wanting to make sure that this work that we're suggesting now maps into that work that we've already done. But in SNOMED, it'll look just like as it is. It won't change as it is right now. All right, next slide, please. Oh, questions, holding them in. Okay. So next question, gravity, food insecurity, working definition. A couple updates here that are really quite interesting. So next slide, please. As I mentioned, it's been a flurry of activity over the last week to 10 days. And one of them was a last minute suggestion to adapt the food insecurity working definition for our project. And if you want to remind you, the definition used to be uncertain, limited, or unstable access to food that is sufficient in quantity, adequate in nutritional quality, culturally acceptable, safe, and acquired in socially acceptable ways. You can see here after the colon that it's changed to adequate in quantity and in nutritional quality, culturally acceptable, safe, and acquired in socially acceptable ways. And I'm going to explain why. So really, it's due to the thoughtfulness of the American Academy of Nutrition and Dietetics, which I have the honor of speaking to their intelligence, and Donna and Tina chime in. So one of the thoughts that they had was having the same word, adequate here, or sufficient, just is clearer syntactically. So having one concept across both quantity and nutritional quality is clearer. We did a deep dive investigation into the definitions, and the words as investigated, although they may carry a sense of difference, are really interchangeable when it comes to their definitions within medical dictionaries. But the thing that adequacy offers that sufficiency does not is the following. It has deeper meaning in the literature of the Academy. The nutrition care process terminology uses the word adequacy throughout to discuss when intake is compared to a reference standard. An example of this are the dietary reference intakes, a common set of reference values shared by the US and Canada. Thus, using the word adequate rather than sufficient is a further step towards clearly grounding our work of gravity in standards that are defined, understood, and measurable. So again, last minute, Donna and I had lunch twice this week in order to refine this. Any thoughts about that change? Really, it's just trying to make sure that we know what we mean when we say important words. And the capacity to, the fact that within the A&D, adequacy clearly represents the application to a standard that is measurable and defined, just seems too important to not employ in this instance. Any thoughts or concerns there? We're quite a crew today. Well, all right. I think that's the end of my slides, and now Donna's going to take it away.
Sarah?
Yeah?
Yeah. I think for someone who hasn't thought about this a great deal, this seems like a wonderfully comprehensive and evocative definition. And I would just like to ask, maybe this is out of scope, but if this is presented to a provider who has to check boxes or enter something in a record, that's one thing. If this is presented to a consumer patient, I am wondering how different the responses might be. In other words, I guess gravity is really aimed at providers of everything that we're talking about, but this definition is so expansive and rich. I'm wondering about how patients would actually answer this if asked. Is that something for us to consider, or is it really out of scope?
Well, I don't know if it's out of scope, because one of the reasons that we built it out this way and based the definition on the quotes from Tufts is that she really takes care to name the dimensions of it very clearly. So in, for instance, some of the USDA work, the cultural acceptability element is not clearly explicitly stated. And safety is not necessarily as clearly stated. So that is interesting future work, I think. One of the things about gravity is there's a million different ideas for how to show we're, how to study all the things that we're creating. But I do like that idea. Oh, and this is Lisa. Oh, okay. Is there a question from the comment box that I can address at this time? Self-defined adequate. Typically, so this is oh yes. So there's two answers to this. So Lisa, I'm assuming this is not our Lisa Nelson. This is so different Lisa. Asked, will the patient self-define adequate? Typically, clinicians would try to define or equate adequate in terms of some measure. So in the simplest sense, we do have the screening tools that the longer screening tools certainly parse out all of these concepts, such as the USDA food security module, the Canadian module, the FICE. They all definitely go into what the experience of adequacy would be like for the person. Some of these concepts do not have measures yet, but again, it's similar to the terms, we build space for them. And then lastly, a whole other side element of my work is really trying to develop diagnostic criteria for these concerns. So just in a conversation with a patient, one could gather enough history to understand the patient as food insecure in their own words. So I hope that's an answer to your question. And again, the point of choosing adequate in this sense is that it is applied to standards that are commonly understood across settings because of the work of the A&D. Any other questions before we move on to Donna? Welcome, and thank you for your patience and for your very, very intense work on all of the slides that were before.
Thank you, Sarah. Next slide, please. So I'm here today to give the latest update on the end-to-end comments that we've received. Next slide, please. And this one actually answers a question in the chat. So how timely. This is terrific. I'm going to go through the information the way I did last week by starting with screening and assessment. Then we'll talk about proposals for diagnosis, goals, and the interventions. In screening and assessment, it was brought to our attention that the American Academy of Family Physicians has a screening tool where 2 questions, 3 and 4, relate to food insecurity. These happen to be the hunger vital sign questions. And so it's the recommendation then to add this tool. So that will be part of the master when you see it. Next slide, please. In terms of diagnosis, there is the proposed code. This is something that Sarah has worked on for ICD, patient noncompliance with dietary regimen due to financial hardship. It was brought to our attention that the parent of this particular code was not included in the proposed master, and so it was recommended that that be included to make more sense having these 2 concepts there rather than just the one. So it is our recommendation to add the parent. Everyone, of course, reviewing this slide or hearing the concept of non-compliance, I'm sure it's a little bit uncomfortable because there are certainly many factors outside of a patient's control that may impact their ability to follow a dietary regimen. But this follows the existing concepts that are in ICD. So just to give you our thoughts about that particular one and give it some context. Next slide, please. So we have spent some time, we did talk on the last call about goals. We've got a lot of good feedback and we want to spend a little bit more time talking about that. These numbers that are next to each particular concept here align with what's in the master. We talked last week about possibly rewording the goal food security to something like client achieves food security. We received a lot of feedback on the call, and we really appreciate everyone's thinking on this. There are a lot of potential perspectives. Certainly, the patient could establish a goal around food security, the provider itself, organizations also might frame that for themselves. And because of that, at this time, the recommendation is to maintain the core concept, the core goal of food security, but not add any verbiage around that so that it could be flexibly used by whoever is creating that particular goal. There are two other goals, one that has the concept of both screening and intervention, and then the concept of the one goal that just includes screening. And the recommendation wisely came forward to have two separate concepts, one that is clearly for screening and one for intervention. The nice thing about these is that any of these goals could be combined. Oh, I'm getting, sorry, got a lot of feedback there. Could I just ask everyone to double check that they're on mute? I'm getting a lot of feedback. Okay, that sounds a little better. As I was saying, the nice thing about what we have here is with these various goals individually defined as concepts, they can be put together. So if you would like to identify screening and intervention with these two individual concepts created, they can be combined and metrics could be developed or studied around those. Next slide, please. Continuing in the area of goals, one of the really important pieces of feedback that we received was the way that these were phrased. Not really that we're interested in a past tense concept of decreased severity of food insecurity, but looking at the decrease in severity of food insecurity. I'm certainly not giving justice to the feedback that we received, but I think that you understand the intent. So we're trying to phrase this in a way that makes more sense, and that in this situation, if you have the concept of decrease in severity of food insecurity, one could make an assessment that that goal was achieved or not achieved or somewhere else on the continuum. The decline in prevalence of food insecurity is also a goal that's in this data set. And we just wanted to acknowledge to the organization that submitted this comment that it does indeed involve the analysis of food insecurity status for groups of individuals. So this would not be something that would be done per se, an analysis of a population. It's really a collection of individual data that then could give information about a population. There's also another recommendation, and we received this from a couple of groups, to add a goal, and we are supporting the addition of a goal regarding access, nutrition, and food support program resources, because this is something that certainly is important to think about and perhaps find ways to address if there are barriers in access to those resources. So I'm going to pause there because I just covered a whole lot from screening to diagnosis and goals before I head into interventions and program definitions. So Ken raises a really important point, and that's absolutely true, that food security can be directed toward other concepts in terms of reduction in hemoglobin A1C or other types of objective measurements. And absolutely, that is the case. And I think that these particular goals and this data set will be really important to be able to make those kind of assessments to see the impact that the mitigation of food insecurity could have. Absolutely.
This is Sarah. I just want to chime in that the literature regarding those concepts is fairly complicated, though. There's so many regional, ethnic, and income level variations on clear associations with many of the concepts of health risk and food insecurity. So one of the hopes is we can actually really lovely granular research once these terms are in the record.
Indeed. Does anyone else have any other questions or concerns about the recommendations that we're bringing forward?
Could you comment about financial hardship? I put it in the chat. What does financial hardship actually mean? That there is no money to buy the recommended dietary regimen, or there's no money for everything, or to me, it's a pretty broad concept. And I'm wondering what is the understanding about how it applies in this context?
So building off of other concepts directly regarding the ability, the income, the person, so it's not financial strain, which is a concept of itself. It's independent of financial strain. That code is representing when limited financial resources have disabled the person's ability to follow the regimen itself. So of course, there will be co-occurring themes. You can imagine someone who has limited ability to follow a prescribed dietary regimen. Secondary financial hardship might also have limited ability to follow a prescribed pharmacologic regimen. So these things can overlay, but it's specifically that I do not have enough money to do what I'm supposed to do dietarily.
Next slide, please. So this actually does bring up this same concept again in the intervention data set. We realized when looking again at the proposed ICD-10 code, patient noncompliance with dietary regimen due to financial hardship, that we lacked a counseling code related to socioeconomic factors. And so we have proposed that this particular concept be added specifically as a response to this particular ICD-10 code. Another piece of feedback that we received was the need to clarify the location of the food provision. Provision of food is an existing concept in the master, but what was requested was a distinction where groups could identify that provision of food occurred at a community site versus provision of food at a clinical site. And in response to their recommendations, we have a suggestion to add 2 children of provision of food, as you see here. Next slide, please. It should have occurred to us at the time that we created a concept, education about nutrition and food support programs, that we needed parallel concepts in the other intervention categories. So we have a number of individual codes, for example, education about the WIC program or education about the SNAP program. So a parent concept to make it easy for those who are looking for a little more streamlined approach, we included a parent education about nutrition and food support programs. So we recommend doing the very same thing in the area of referral to and assistance with application. These would serve as parents to all of the individual referral and assistance program codes. So you'll see these based on this recommendation in the master. And it also then led us to a recommendation to change a current concept where we were trying to achieve the same thing, having a parent code that was more general, and we just scrubbed up the wording to make sure that it matched the other concepts. So I'm wondering, it looks like there's been some questions about the community versus clinical concept. These particular are locations where the food is provided. So an organization that's community-based would then designate that they provided the food from their community space versus someone who would designate that they provided food at their clinical space. Certainly, I think that there is the potential for organizations to designate themselves to determine how it is they would use those codes, whether or not they consider themselves more clinical or more community-based.
And I do want to say this is so fresh that we haven't yet defined these concepts in our program definitions, but the way it was framed really came from some work that we were doing with the Action Center and other submitters. So everything involving mobilization of community food resources, whether it be the mobile food truck that comes and parks itself at the clinic, or kitchen, or the food bank, or the food pantry, those would be community sites. And then, because there are some places like the ProMedica model that deliver food right in the clinic as part of their programming. And so that was their desire to capture this nuance. This is a first stab at that. It might not be as best as it can be, because again, this is very fresh. We were trying to integrate this concern that was asked very clearly by one of our partners, and we're wondering about your feedback.
Sarah, this is Lisa. Just to maybe start a little dialogue about this. It's interesting, you know how we talk about like lumpers versus splitters, and I think there are folks that are more oriented towards pre-coordination of concepts inside the codes and reliance on the code system versus people who lean in the direction of structural constructs that allow you to take a set of concepts like mode of delivery or location of delivery and identify a value set that's specific to that notion and support post-coordination through a data structure that allows you to kind of plug these concepts in together without creating a whole bunch of pre-coordinated codes. So I think we might explore the idea of the difference between things that are fresher or more emergent versus things that are really proven and well established, and maybe experiment with the idea that while things are more emergent or fresher, that you might look at using some additional structural concepts until enough learning is done that conclusions are drawn, and maybe these notions of combined or pre-coordinated concepts really make sense to be encoded in the code system. And maybe in the early days, when we're exploring things, you would more want to identify where the community is saying, well, we think this is important to distinguish where it's delivered. And so there's 5 or 6 things that are being tried in different communities, and we at least need to be able to say these 5 or 6 things so that we can start to document that and study it and look at it in a consistent way across many states or many activities, many programs. And then as we learn more, we either decide to go further with the code system or maybe expand that value set to include more creative possibilities. I just think that we have to balance that tension between making everything pre-coordinated in the code system versus identifying some useful value sets that we can structurally combine with other things that we're saying a little bit more flexibly.
What I'm hearing, this is one of the instances where we hear these children until implementation and testing. Is that correct? Just to roll it out as is and then see how it works and then go from
Yes, yes, absolutely. And one of the things that we are working on and experimenting with in this IG effort is the notion of having placeholder codes so that we can move concepts that are defined and identified by the community into use and testing, and then as our code system steward partners are watching this work and keeping pace with us, and the tests are proving out and the community is settling in on what really turns out to be most useful and effective, then we can work with our code system partners to establish permanent codes with the concepts that we accurately need to express. And they can identify the right hierarchy or placement or whatever and deal with that based on the definitions that we've tested to be and proven to be needed. So I think that one of the things that as we explore this, that we definitely feel comfortable with is the idea that these recommendations have an opportunity to be played out before we ink them in the code system.
Thank you, Lisa. I think that really helps everyone understand sort of how this might move forward and how we might make decisions around these. So I appreciate that. Why don't we move on to the next slide? Certainly continue any other thoughts that you have in the chat. We've just got 2 slides left to talk about the program definitions. These were presented a couple of weeks ago, I believe, if I'm remembering my Gravity presentations recently. And we received some terrific feedback on the program definitions themselves. So for the child and adult care food program, the clarification recommendation is to identify that these are reimbursements from the CACFP program and that it excludes programs receiving reimbursement from the National School Lunch Program. And so I think this helps clarify the distinction between these particular types of activities and those of the school meal and snack program. Next slide, please. And speaking of that program, the school meal and snack program, we've added a clarification that was suggested to indicate that this is happening throughout the school year and includes funding from the National School Lunch Program or another nonprofit. And again, this is an important distinction from the previous program, which also offers snacks. And so we wanted to make these 2 programs with regard to after-school snacks a little bit clearer. The summer meal and snack program, we've also accepted a recommendation that was very important, that we left out the concept that this is happening during out-of-school time. And while summer is generally the focus of the program, this is also a program that can operate holidays and weekends. So that distinction has been added to these program definitions. So I see the question about out of school time. I don't know. I'm wondering, Sarah, do you know if this happens during emergency school closures?
It
I'm
depends
thinking,
on the region. At times it
Yeah.
does, but at times it does not. It depends on the implementation of in the
program.
district.
Yep.
But there certainly are some that do.
Great. Are there any concerns or any questions about those modifications to these definitions? I'm not sure, Lucy, whether or not we should add that. We certainly could identify that summer holidays and weekends are examples, because there could be groups that do have other situations where they might use those. I think the important distinction here is the during out of school time. So I think it probably is wise to add that summer holidays and weekends are examples. Thank you. All right, so with that, I am concluding my remarks for today, and we move on to some of our next steps. If you want to go to the next slide, please.
Thanks, Donna. Yes, for next steps, we want to remind everybody that next Thursday, the 21st, is when we will reveal the process for consensus voting, and we will provide you with the latest version of the summary sheets that identify all of the changes that we've been making during the end-to-end review process. So please, that's important to join us to learn more about that, because we really need everyone's participation in the consensus voting. And this next one is just our normal reminder about joining the Connect-a-thon event, and we will get more information from that from Lisa in upcoming presentations where she'll talk about the Fire IG development process. And I see, is there a, oh, okay, this latest chat, it looks like we're going to follow up. Lisa will follow up with Jane to be clear. So again, we're almost at the top of our closing hour. So again, thank you so much for participating in this process. We really appreciate all this great input. It's a good chat period and question period. And we've really seen that in the past few weeks as we've gone through a lot of the comments from the end-to-end review. So looking forward to presenting our next steps next week, and everybody have a great rest of your day. Thank you.
Thank you so much. Oh. Do we have a, so Lisa, do you have an answer to the question from Eric John? She might be up.
Yes, it is, Eric.